parto a una pequeña introducción. Gracias por el interés en la charla. Argi es un colega y amigo, nos conocemos hace como 4 años. Empezamos a colaborar en una conferencia en Austria, en la que prometí que podíamos hacer muchas cosas con medios porosos. Yo creo que una publicación y casi otra después, todavía no logramos ni un tercio de lo que hablamos, pero ha sido un encuentro productivo. Estudió su bachelor y magíster en matemáticas aplicadas en la National Technical University de Atenas. Después se va a hacer un doctorado en matemáticas Simon Fraser. E hizo un postdoc en Beckham, en Bilbao. Después trabajó en un grupo en Bordeaux, si no me equivoco, que se llama LYRIC, de modelamiento cardíaco. Y después fue a donde está actualmente, en RICAM, en la Universidad de Johannes Kepler, en Austria, que es el Radon Institute for Computational Applied Mathematics. ¿Sí?
Sí, sí.
Perfecto, donde ahora es senior scientist. Hoy día nos va a hablar de modelos de ablación cardíaca en inglés. Así que, Arji, it's a pleasure, please go.
Ok. Gracias por la introducción y muchas gracias por todos para estar aquí en presentación. I'm not going to give a presentation in Spanish, I just want to say some words. So it's a great pleasure to be here again visiting Nick and you from the Universidad de Chile, the Pontificia Universidad Católica de Chile, sorry, the UC Chile. And for this talk, I would like to present the things that we have been working on for the past 9 years. We started at least 9 years ago, and then it's still our ongoing work with our lab. So to begin, just to give a brief context, cardiac ablation is, we start with cardiac arrhythmia, which is a pathology that affects quite a large portion of the population. In Europe only, they expect that it will correspond to about 10% of the population above 65 years by 2060. And by cardiac ablation, it's considered any kind of disruption to the electrical activity of the heart. It can be fast, slow, or irregular. Here, for example, we see a case of atrial flutter, where the atria conduct twice as fast as the ventricle. So you see 2 contractions of the atria at the same time, 1 contraction for the ventricle of the heart. And some arrhythmias can be a bit more serious than others, and in such cases, typically a treatment is required. So the first line of defense that typically people consider is what they call cardioverse or antiarrhythmic drugs. So they take some beta blockers and they see whether the arrhythmia can be controlled somehow. And in severe cases, typically people opt for catheter ablation. Now, in terms of catheter ablation, essentially, the ablation aims to destroy some small parts of the tissue that are considered arrhythmogenic, and in order to restore the normal cardiac electrical wave propagation, electrical signal propagation. So it's minimally invasive. Typically, it considers a cable that goes inside the patient's thigh or groin, and through the main vein goes all the way in the cardiac chamber of interest. And their aim is to perform multiple applications wherever it's required in the heart in order to produce scars. And these scars electrically insulate these specific parts of the heart. And by essentially repeating this process, we can get insulation lines and the corresponding restoration of the normal heart rhythm. At least that's the aim. Now, in terms of cardiac ablation, there are many different types of ablation depending on the energy that the ablation uses. So, for example, radio frequency ablation and laser ablation are typical thermal treatments, while cryoablation is more like a cryo treatment, so a treatment due to freezing. And we also have the pulse field ablation, which introduces damage through very high pulses, and it characterizes, it's being characterized, the damage via electroporation. And we have been working on radio frequency since like 8-10 years ago. We started 2-3 years ago for pulse field and laser ablation, and next year also we aim to expand on cryoablation. So let's start with radio frequency. Yes.
Question. So when you say you're gonna start simulating, or are you gonna start treating? Are they already doing these experiments with animals, or?
These are actually treatments, so it's not that they.
But they're already current treatments that have
Exactly.
gone through all the testing, and so they do them in humans.
Yes, they actually do all those in the hospital for humans. And depending on the arrhythmia, they choose for the corresponding energy. And the most recent one is the pulse field ablation. So now for atrial arrhythmias, they use solely, almost solely, like 70-80%, use this energy, while for the ventricles, they still consider radiofrequency ablation. And cryoablation, now it's been less used, to be honest, for cardiac applications, but it still has many applications for different types of organs. Laser ablation was typically introduced for targeted ablation. Just it's a very precise approach, and it was typically used so far for tumors, and we did a proof of concept for cardiac applications. But we also consider a model for a liver application on a tumor. So, by the way, thank you for a question, and please, if you have any questions, just ask anytime. So let's start with the work that we did on radiofrequency ablation, on this type of energy. So this is a treatment that has been performed for 30-40 years now in the clinics, and it's a type of treatment that radiofrequency current at 500 kilohertz travels through the catheter cable all the way to the electrode, and it's delivered to a resistive medium, which is the tissue, the cardiac tissue. And due to this resistive medium properties of the tissue, it creates also resistive heating. And resistive heating only close to the electrode, and then we also have the propagation via the conduction, the heat conduction. So a dispersive patch typically at the back of the patient closes the circuit, so this is the return for the electric current. And a lesion is formed at temperatures that are higher than 50 degrees, and so that's at least the consensus. However, we might have complications, so we cannot just keep heating and drive the heat as high as we want. We need to be very delicate with these kind of procedures, because overheating of the tissue at about 100 degrees introduces boiling to the tissue water, and pressure builds up inside, and this pressure actually can cause steam pops, so tissue disruptions. And these steam pops are actually audible, one can hear them. Pop. And then when we ask the doctors what do they actually do, they say, oh yeah, we just put a hose and send them to the ICU. We patched through.
So just to be clear, you still what you want to burn something, but not too much.
Exactly.
And that's why you need higher than 50. So the higher than 50 is a good thing.
Yes.
But you have to keep it below 100.
Exactly.
Okay.
So these are some controlled values. Yes. And the higher than 50, it's because it introduces an irreversible thermal damage, so the lesion, the scarring in the heart. Now, on top of that, it's not only.
But that's something you want. That's carrying.
Exactly.
Okay.
that's the aim actually of the procedure. So we need to create this scarring because it electrically insulates the heart. So on top of the control for the tissue temperature, we also have a control for the blood temperature. Because if we get the blood overheating at about 80 degrees, then the proteins of the blood denaturate. And they produce this black substance that typically sticks to the electrode. And this, so this one essentially insulates parts of the electrode, so that can be dangerous. That's one part. And the second part is that if this detaches from the electrode and it traverses the circulation system, the blood circulation, then it might create a thrombus somewhere. So that can also be a dangerous scenario. And further, another typically fatal complication is esophageal lesions. So we are ablating the heart. Why is the esophagus there? So the problem is that at some area of the heart, particularly of the left atrium, it's right opposite to the esophageal wall, and they're extremely close to each other, some millimeters apart, maybe like 2 millimeters. So it's super close. And by hitting the wall, if you end up hitting too much, the heating goes all the way to the esophagus. And it creates esophageal lesions. And the worst case scenario is this, what they call atrioesophageal fistula, which is essentially a corridor that takes from the esophageal lumen to the cardiac lumen. So you have a sterile environment exposed to an environment like the esophageal lumen. So it's a terrible scenario. The mortality rates are 70% in case that happens. So they really try to avoid such cases. Thankfully, it's the percentage of cases that happens like 0.1%, but still 0.1% of millions of patients, it's not a small number. So how do we model such a complicated system? So when we started formulating the problem, we started considering the different physics that are involved in the application of radiofrequency ablation. So we considered the blood movement through the Navier-Stokes equations, which contributes to the corresponding cooling part of the thermal problem that, of course, we're interested in because we want to keep track of the temperature. And using this bioheat equation, which essentially it's a heat equation, advective cooling term from the Navier-Stokes, and a source that comes from an electrical field. And the electric field uses this equation that is augmented with a constant power constraint for constant power ablations that are typically done in the field.
There's like some sort of joule heating that's going into that.
That's right. Mm-hmm. And we also introduced a tissue deformation, and it was one of our first works. And we showed how important it is in order to properly estimate the amount of power that dissipates in the tissue. And this one comes from the typical motion equation plus frictionless contact mechanics. So let's see one by one some small details on what we do. So in terms of the Navier-Stokes equations, the blood flow for the domain that we consider is actually a turbulent flow. And so we needed to use some stabilization approaches. So the previous approach that we used had like it had a stabilization term and adaptive time step, but at our latest implementation, we consider DMS-less formulation with SUPG that was introduced by Mansal, Professor Barnafi here as well. And so we opt for this approach. In terms of the bioheat equation, now, although we don't have the velocity anywhere, the blood velocity everywhere, we still have the blood subdomain. And in the blood subdomain, the problem becomes actually advection dominated, because this coefficient is about 10 to the power of 6. And this coefficient is about 10 to the minus 1. So we have a heavily advection-dominated problem. And so we needed to use a stabilization approach. So we opted for an SUPG approach as given by the book from Quarterot.
Here, the domain is different than from the fluid domain, or is this the same domain?
So here so this consists of the entire domain so it consists of the blood subdomain, the tissue, and let's stay at the in vitro case. So at the case that we have a small domain, the electrode, the thermistor, that's part of inside the electrode, and the board, the methacrylate board, the plastic board. So this kind of equation is solved everywhere, but only at the blood subdomain we have that.
U.
Exactly.
And then
That it
at
dominates.
the other subdomains, it's 0, or?
Exactly, because there is no blood flow.
And then I guess that C is also changing a lot. That C of T is also changing depending on the subdomain. The coefficient of.
Yes, exactly. We have a very, very big jumps of coefficients as well.
The heterogeneous and.
Or actually all coefficients.
Yeah, yes.
So that is for the thermal problem, and then we go for the heating problem that we need to impose somehow this constraint. And as we showed in our work here, essentially what we opt to do is we change our Dirichlet boundary condition in order to match the power, the asking power that we would like to dissipate. And this, due to the linear coefficients sorts, so we can do a one-step solution that just looks like this, and more details you can find on our work back in 2019.
That P was power from the ablation from that you feed onto the P over in the left.
Yes. So typically on the ablation devices, you can set a specific power that you aim to dissipate in the entire system. And so that is the corresponding power that we have here, the asking power. And essentially what we do is that we solve once the equation with some voltage applied on the boundary, we get some power, and then using this approach, we can just obtain a new boundary condition based on the asking power that we want, and we can just solve once again and we match exactly the power.
That sigma is like the permittivity or something like that?
It's the electrical conductivity of the different domains.
Okay. And is this also solved everywhere? No.
Yes,
yes.
That is solved everywhere because it's actually the heat source here.
Yes.
So that's why we need it everywhere.
Yeah.
But very good points. Thanks. And in terms of the tissue deformation, so we consider in our case, we don't opt at the moment for a dynamic approach. We solve the corresponding static problem and we impose it typically on the geometry. And we only solve this for the tissue domain. And we use a SIG hyperelastic orthotropic material because the heart has fibers, and depending on the different directions with respect to fibers, we have different tissue stiffness. And we impose the Hertz-Signorini-Moreau boundary conditions for frictionless contact. And we impose that at the boundary where the electrode is. And we opt for a specific augmented Lagrangian approach because introducing just a penalty approach by itself, it introduced some quite large errors for the corresponding indentation. And we needed either to fine-tune this epsilon or, I don't know, to do something different. but by considering also augmenting it with a Lagrangian here term and opting for Zhao update, you can actually get the corresponding deformation to be exact based on the indenter. And for the indenter, we consider a gap function that is actually the distance of the rigid indenter, in this case, to the elastic medium. More details you can find on the book from Yastrebov on contact mechanics. So, okay, when we mentioned before, as we spoke before at the introduction, we said that there are some temperature thresholds that we would like to have in the tissue in order to introduce a lesion. Now, there is no consensus, and of course, it's not that we just hit a temperature and then the tissue instantly dies. So there is actually there are some more complicated dynamics involved at the back, and this is our approach for considering the thermal cell death for cardiomyocytes, and we opted for a 3-stage cell death model. So this is a model that considers the cells to be at the beginning at their native state, and when some damage is inflicted through the temperature, they go to the unfolded state. And from the unfolded state, they can either receive irreversible damage and go to the denaturated state, or they can recover due to some cellular protective mechanisms, and then they can just bounce back.
This unfolded is something abstract? It's like an abstract concept? What do you mean by unfolded?
So unfolded, so each cell actually has some proteins, the heat shock proteins, that their aim is to protect the cell from the thermal damage. And so these get activated. That's why after some time, the cell will either survive or not. So it's this in-between state. I received damage, but maybe not enough. And so these are this model, the fast cell death dynamics. And in terms of the slow cell death dynamics, because this procedure might take actually a few weeks. So we opt for a typical approach which considers a threshold at the amount of native cells. And as observed here, for a number of different cells, if the cells are below, if the native state of the cells are below this threshold, then they eventually die. And our contribution here was that we actually considered a different energy absorption rate for the transition state from the native to unfolded, from the transition of from the native state to the unfolded, because that's something that has been observed for a different amount of cells, that the energy absorption is very different with respect to different temperatures. And so far, it has never been considered before our work. So essentially, the way that we solve this system of equations is of ODEs. Is we typically do it at the post-processing stage. We just analytically calculate the first order implicit scheme. And we have our corresponding ablation time, which can be for some protocol, some specific power and specific seconds, amount of duration. And then we allow for some cooling that corresponds to 30 seconds post-ablation, so that we have a thermal relaxation. And then we continue by imposing the corresponding body temperature for a final time of about 30 minutes. So that was for cardiac, for cardiomyocyte damage. Now, as we mentioned, one of the main risks of radiofrequency ablation is esophageal damage, and that can be fatal. So we also opted to create such a damage model for esophageal cells. And what is the difference between the two types of cells? Cardiac cells are permanent, which means there is no tissue, there is no cellular turnover. So the cells do not regenerate, they just die. But in terms of the esophagus, there is actually a cellular turnover. So that's something that we should consider in the model. And this is actually the term that we introduced here, that from the denaturated state, due to the cellular turnover, they can actually come back to the native state. And this kind of turnover occurs typically in about 2 weeks. So this was yet another challenging task to introduce in the model. So because of the properties that we would like to have, so of course, no cellular turnover when no damage is inflicted, minimal damage when we're very close, of course, to when we have very small values, and when the cells are almost all of them dead, then we just want no cellular turnover. Essentially, they receive quite a lot of damage, and that is the reason why we opted for the gamma distribution function. And this model, we could actually calibrate it based on some specific set of conditions that we could find in the literature. Of course, we would love to have exact data, but such data don't exist, and we try to do things in an implicit manner. And so these were the sets. For example, there is light damage for 50 degrees Celsius up to 30 seconds. And then they typically see severe damage at 60 seconds or higher for some duration. And that we also have esophageal cell turnover. At about 80 days, we have 80% of them actually were immune. And so we ended up modeling this aspect. And one thing that one should notice here is that for a cooling of 60 seconds, of 30 seconds, 60 degrees, we do get that the esophageal cells are not permanently damaged. Why is that? So keep in mind that the heart cell, the cardiomyocytes, they have the blood, and the blood cools the ablation site. So there is this cooling source. But when it comes to esophageal cells, there is no such cooling. So when the esophagus is heated, then the heat remains there for much, much longer until eventually it diffuses. So that's why we have a completely different model with respect to cardiomyocytes for such cells. So with a bachelor student, with Laura Fussell, that she's finalizing now her bachelor thesis, we aimed to assess an aspect that is very common in ablation procedures. So typically, what they were doing is that they were doing tests on what is called in vitro setups. In vitro setups is essentially they take the heart of an animal, then they just make it flat, they put on top of plastic board, dip it inside blood, and then with a brace they hold the catheter, a pump pumps blood at the ablation site, and then that's how they were typically testing catheters. And before going to the in vitro case, where they were actually doing the experiments inside, burning the hearts of different animals. And so we aim to assess how this actually affects the corresponding results that we see in terms of the lesion. And so what we see is that when it comes to the electric field, because of the plastic board at the in vitro setups, the electric field does not penetrate. So it just tries to bypass around this plastic board and go to the return electrode, which is typically underneath that board. On the other hand, when it comes to the in vivo setup, we see that the current can just flow through because behind the heart we have the pericardium, and then we have the different organs until we hit the dispersive patch, which is typically placed at the back of the patient or the pig. So we have a very different electric field and corresponding source, Plus, in the in vivo case, we have the blood perfusion that cools actively the site. So we compared for two different powers. For a standard power, which is 30 watts typically for 30 seconds, and for high powers, which they consider 90 watts for 4 seconds. And what we observe is that we do get much smaller lesions in the in vivo setup for standard powers with respect to in vitro, while for high power, they're mostly similar. And this happens, of course, because also the perfusion requires some time to actively cool the ablation site. And let's go onwards to our virtual patient cohort. So this is a work that has been done with my PhD student, Minhan S. And at the moment, we have a virtual patient cohort of 8 patients, 8 humans, 3 females and 5 males, and 2 virtual pigs. And so essentially, I would like to just give some details on how we create these kind of models. Because that is something that at every paper, it's just one line. And they just say, we just created the mesh. Perfect. But there is so much work behind that it's definitely undermentioned there. So typically, we obtain our CT scans from our collaborators from the hospitals, and we perform the corresponding segmentation of the different organs. Now, we use the open source Slicer 3D software, and of course, now there is the AI era, so we opt for an initial guess using the total segmentator, so the corresponding AI. And the problem is that typically the AI sometimes gives you some overly smooth regions or some not so accurate ones, so we cannot see the fine features. So a lot of refining is required later on, for example, to obtain the trabecula inside the heart, or to consider the vessel walls and the walls of the atria and so on. So whenever we can see this data from the scans, we opt to go for the different intensities. And whenever we cannot see them, we just opt to get the values that are available in the literature. And so we approximate it like this. And then the mesh generation. That's another painful process from the segmentation of the medical image. And in this case, we use mesh studio. Studio is actually a commercial software from Numerical GmbH, from some collaborators from Medical University of Graz. And Mesh Tool also has a free version, which is available. You can find it at the OpenCarb website. They also have the Mesh Tool. Or things can also be done in Salome, but they just take a bit long. And Salome is an open source software that it supports CAD generation, meshing, and so on. So essentially, we opt for so any organ or any segment that touches with each other, we consider them as single surface. And we prioritize, of course, the areas of interest. So, for example, we consider as a single surface the cardiac walls and the vessel walls. And then we tag the corresponding areas differently based on closed surfaces that come from image segments. And like that, we can just create 3D meshes and we assemble everything together. Now, this process can be automatized at the moment. It takes us, for this process, I think, 1 working day.
1 or 2 days?
1 working day.
Oh, 1 working.
Yes. Segmentation takes the longest at the moment. Segmentation takes 1.5 to 2 weeks to have very accurate segmentation, because we aim to segment all the organs of the thorax. Then, in some cases, we want to simulate experiments that could be open chest. And in this case, so far we typically use Studio, and we essentially don't remove elements, but what we do is that we tag the corresponding elements as air, and then so you tag them as a different tag, and then of course it has different properties. We impose the properties of air, and we do the same also for the pericardium, because typically they shape the pericardium and they keep it open in open chest experiments. So that can be done easily in studio, but it can also be done in Salomon. If you want, we can discuss further later on how. Then we have the catheter design. So there are plenty of catheters available out there. And for that, we use Salomon in order to try to be as detailed as possible. And we design it based on some catheters available in the market. Then we mesh the corresponding catheter tip. We extend the catheter cable to just match whether we have like a vessel or some distance. And then we mesh the corresponding catheter for that. And then it's the embedding. The embedding is not as simple, actually. So to put the catheter embedding to the corresponding ablation site, okay, we use these tools. We need to create a hole in the mesh. And then we superimpose the two meshes, and we fill the hole with elements. But by doing so, essentially, you disturb the corresponding nice and smooth surfaces that you obtain from your mesh here. And to fix that, essentially what we do is we remove locally some elements and we stitch the corresponding parts to make sure that we match exactly the mesh of the surface of the electrode. So we have an automated code to do that now in Salomon. And finally, in order to get the dispersive patch, we can just tag the corresponding surface with the size of the patch, and then we can actually get meshes that look like this, and we embed the corresponding catheter to the different areas of the heart. So through this procedure, we could actually perform different studies on our patient cohort. And one thing that we wanted to do is that for left atrial ablations, which is typically a pulmonary vein isolation, we opted to use 4 points per vein plus an ablation point at the posterior wall. And we wanted to assess what happens for different sexes or for different BMI. So essentially what we observe is that for different BMI, we have that for obese patients, we do obtain a higher impedance, while for normal weight patients, we have a lower one. However, this change is not really translated to the tissue power. And in terms of tissue power per vein, we see that in some cases, like in the left superior pulmonary vein, we have higher power dissipated at obese patients with respect to the normal ones, or some different trends. But essentially, this is the striking difference, which is one of the numbers, the impedance, that is on the radiofrequency ablation generators. And that's something that the doctors observe. And when it comes to the impact of different sexes, male or female, for example, we see minimal differences in terms of impedance and tissue power overall. But we should be rather careful because for females, it appears that they have some larger distribution for power dissipation per pulmonary vein with respect to male ones. So that's something that can create a variability. Why were we considering?
Yes. Below is all pulmonary vein, you said?
Yes. So this is the right superior and inferior pulmonary veins, the posterior wall, and the left inferior and superior pulmonary veins.
Yeah, quite a difference.
Yes, and the reason why we did these two studies is that for patients with high BMI, obese patients, they observe a greater relapse. So normally, ablation procedure at 1 year is successful in 70% of cases. In 30% of cases, they go to have a redo procedure, is what they say. And in many occasions, they can have multiple procedures. For obese patients, this percentage, the percentage of success is lower. It's actually 60% per year, at 1 year. And it becomes dramatic for longer time. So that's why we aim to explore what happens in the case of obese patients, because also in some cases, the hospitals do not accept such patients to treat such patients. So they completely reject.
Now, do you change the parameters of the patients, or this is a purely geometric difference?
In this case, it's purely anatomical because we don't have different parameters available in the literature. But essentially, we segment everything in the thorax, which means also the fat and the muscles. So for obese patients, we can see the difference in the amount of fat in the torso. And for male and female, it has been observed that more complications happen in female patients. And we aim to explore why does that happen. And so this variability might be one of the reasons why this happens. And in terms for extensions to porous media, with Nico, we have been trying to develop a nonlinear thermal equation that is coupled with a porous media equation and the electric potential in order to characterize what happens within the tissue with respect also to the blood flow therein. And what we can observe in our preliminary results is that we can get a very nice effect, which is the tissue dehydration that naturally comes close to the ablation site for high temperatures. And that is actually a very exciting first step. And we are close to nailing, I think. This week has been very productive.
That thing below is fine, that's the electric potential?
It's the porosity. So this is the tissue porosity. And we see that locally where the temperature rises, we have a much smaller porosity because of the dehydration locally. So you also want to further discuss on that. This is something that we're actively working with Nico, so you can always further chat at the office as well. So I'll move on a bit to the different energy, to the pulse field ablation. We'll go a bit faster. It's a different type of treatment, and it consists of very short, very high voltage pulses. So when we say short, we mean at the order of microseconds long. And when we say high voltage, we mean 1,000, 2,000 volts. So this kind of pulses introduce pores in the cellular membrane. So holes open at the cellular membrane, and then this creates a different cascade of events from nanoseconds to microseconds all the way to hours. So these holes essentially create highways for ionic exchange between the intracellular and the extracellular space. And then, even though when the pulse is not active, even though the pores close when the pulse is not active, we do see that the membrane actually gets oxygenated, which means that it remains permeable for quite some time. So this still allows for ionic exchange for up to minutes. And then after this exchange happens, at minutes to hours, what happens is that the cell either will survive, which is called reversible electroporation, or it will permanently die, which corresponds to reversible electroporation, and this will lead to different cell death mechanisms to be triggered. Now, this treatment has funky catheters. They target large areas. However, it has very different complications. So it can lead to vasospasms. So this kind of closure of the coronary arteries, which can be quite dangerous. It can lead to muscular contraction or even jumping of the patient or the pig from the bed. So we had some experiments a month ago, and we actually saw that pig almost fell. So it can be quite violent, depending on the waveform. And it can also introduce gas bubbles, which can lead to cerebral lesions and strokes. So
Is it used a lot?
yes, it's the big thing now, actually.
Is it less dangerous? I mean, as in the percentage of
Yes, actually,
than the other one than the.
it depends a lot on the waveform. And the company essentially, they threw a lot of resources to optimize the waveform. And now things have been better. But for example, last year, a catheter was recalled from Johnson & Johnson because it had a high incidence of strokes patients.
Catheter, the other one.
No,
Or this
this kind. So it had about 3% incidence of strokes and from the treatment, and it should be under 1%. So the FDA recalled the device. It's a very new technique, especially for the heart. It has been used for different kinds of applications, and so the excitement that they have here is that they don't have esophageal heating, because this procedure is mostly non-thermal, or it introduces very superficial thermal damage. So essentially, everyone was so hyped because there is this fatal complication. But of course, nothing comes for free, have different ones. So typically the people in the field, they just consider on the electric field equation. So they consider an equation like that because they have seen a correlation in the electric field intensity with the lesion size, with the corresponding damage area. And they consider an electrical conductivity inside the tissue that is nonlinear, and it typically has this sigmoidal shape. So the normal tissue has some electrical conductivity, and the electroporated tissue has a higher one. And the transition is through a sigmoidal function. And the threshold on the electrical field intensity, characterizes the lesion. So that's what typically people use. And so we try to explore what happens if we use that approach on a detailed geometry that mimics an open chest experimental setup. And what we saw is that the lesions that we're getting actually don't match the experimental lesions. So these kind of models are actually a bit poor or not fine enough in order to match such cascade of different phenomena that happens in the treatment. And in terms of the updates that we consider, so let me go back for a second here and mention one thing. When people consider this model, they saw a correlation of the electric field intensity with the electroporated area on what kind of tissues. They saw it in liver tissues. They saw it on potatoes, because it's also used a lot in food industry, this procedure. So they tried to do the same for cardiac tissues. And so they considered isotropic properties. But of course, the cardiac tissue is not isotropic. It consists of fibers, and it can have very different properties. So an updated model that we are introducing now, we consider the cardiac fibers, the incorporation of them at the ventricles, where we have the corresponding catheter in our case. And we also consider anisotropic fiber-dependent electrical conductivities. But here we should be careful. So FDA and plenty of of policymakers. They say that we should use the parameters of the ITIS database. ITIS database is a database from for biophysical properties of different tissues that's available from ETH, and it's one of the largest ones. And although they have a very extensive amount of parameters there, they are for humans. So if we want to model a pig, we cannot go and get properties of humans to model that. So when we went to a paper that introduced properties for the pig, we see that for pigs, the corresponding resistivity or the conductivity, which is 1 over that, is almost isotropic along and across fibers. And in some cases, we even have that across the fibers might be a bit large. So we should choose our electrical properties accordingly. And beyond that, when it comes to the damage and the generation of pores of the cells, they don't happen randomly. They are actually aligned perpendicular to the electric field. So parallel to the electric field, there are no pores at the cells. There are only in these areas. So one should take that into account as well, the orientation of the myocyte with respect to the electric field. And finally, also due to such high electric field intensities, we also have that the gap junctions close. So cardiomyocytes are connected together in a cardiac fiber through gap junctions. And these essentially allow for the signal propagation. And cardiomyocytes, when they do have a very high voltage, a very high transmembrane voltage, they close essentially the gap junctions in order to protect the neighbors from the damage. And this happens at an order of milliseconds. So although each pulse in pulse field ablation can be a microsecond long one, the total train of pulses can be of the order of seconds. So that effect is also an important one. And once we incorporate all the effects, we can see that we get a very nice matching of the corresponding lesion with the experimental one.
What was your criterion? When you say very nice matching, I mean, I can draw the same geometry 5.4, but what was the criterion? Draw the boundary, the black boundary on the right.
Yes, the criterion here, it's still the electric field intensity. So we still consider a lethal threshold, as they call it, on the electric field. And it's just that because of all these mechanisms, now it doesn't look this isotropic like before, but it looks something, has a much different shape.
There's a contour plot of some threshold voltage, basically, and it.
Exactly. So we didn't change, in this case, how to assess the lesion. We just changed the mechanisms that are involved in the change in the electrical conductivity. So essentially, we changed this time. And by doing a small sensitivity analysis, of course, we see that the electric field lethal threshold remains the dominant parameter to identify the lesion shape when we measure width along across fibers, depth, and volume. But the second most important one, and it should be considered, is the closure of the gap junctions. And this is one of the reasons why we see these kind of lesions that are a bit longer, not like this. Okay, we have an ongoing project for this type of ablation with Numericor, the company Numericor, and we're actively actually doing experiments, and we tailor the corresponding ablation models. And the aim is to identify an approach to have a protocol-independent way of estimating the damage. Okay, then I will just, I think I will skip laser ablation. If you are interested, you can just go and check the paper. And just on the summary, we have models for these different modalities, thermal and electroporation based. And we also have applications of these models on virtual patients who have a nice, we have a corresponding nice virtual patient cohort that consists of 8 patients and 2 pigs, some automated approaches to embed catheter geometries, our in-house finite element library that is based on PhoenixX, and soon to have a basic open source version, so open version. And yes, with this, I would like to, here's our group, and thank you very much for your attention.
Thanks. There's time for questions.
So you already mentioned a bit, but I'm interested in how do you model the needle, the catheter, because there's to be penetrant inside the patient basically. So it creates also deformation of the nearby tissue. It has an impact on the bioheat equation with the convection, not convection, but with the induction of heat. So how do you model this penetration of the catheter inside the patient?
Okay, it depends on the ablation. So when we have a laser ablation, the laser actually penetrates a little bit the tissue. So it's actually inside the tissue. Actually, there is a small needle somehow. But when it comes to the other forms of ablation, maybe apologize at first. So the first slide, this one. Here they just touch, they don't penetrate. So they introduce deformation in the cardiac wall. So we did model this so far on the tissue slabs, and that was with the contact mechanics, and now we're extending that actually to the geometries that come from the CT scans. So that's part of our ongoing work that we're going to develop probably in the next 1-2 months. We have all the tools there. We just need to set the proper boundary condition.
So you're only touching the catheter. So it's a boundary condition in your model, not part of the model itself. It's part of boundary conditions.
It is part actually of the model. So part of the model is the electrode. So it's this part. And this part, the catheter body, it's considered as a boundary condition for us, and it's insulation. Boundary condition. Yeah.
Questions? One. First question. You're solving 1,000 things. It's very complicated, right?
Yes.
Very hard, which means many things can go wrong, right?
Yes.
So you mentioned like a pipeline just on the geometry side of the pipeline. I'm guessing you have a bunch of pipelines. How do you keep everything together? How do you isolate problems? Because when something goes wrong, it could be 1,000 things going wrong. In general, can you give some general comments? Because there's a lot of stuff going on.
Yes, and other than torturing my PhD students, they're listening, so I have to say that. No, jokes aside, I agree. There are several things that can go wrong, and our aim was essentially to try to go as close to the patient as possible with respect to the geometry, and through that, there are fewer things that we need to tune. And we actually, when we did have the virtual patient that I showed with all the organs, at the beginning, we thought, let's introduce just an electrode, like put a sphere there and see what happens. And the impedance was gigantic, of course, because it doesn't have the same shape as the electrode. And then we realized the need to actually introduce actual shape of the electrode, and then just like that, just by introducing this, we got physiological values. So it was very impressive actually to see that we didn't need to tune anything for these works. And then in the simulations, yes, plenty of things can go wrong. So far, we had lots of problems with the upscaling because it's different to solve a model on a box or a cylinder, which has, I don't know, some thousands, maybe a million of degrees of freedom, so not dramatic. And then you go to the torso that you have close to 7-8 million degrees of freedom with P1. So
I was thinking maybe you have like some sort of like, what I usually think about this is like you have the simplest, still an experiment, but the simplest experiment possible that you can focus, you are confident about this data, and then you calibrate, you use it to calibrate, and then from then on, but you have such like calibration experiments that are like that you trust very much, or you have like some.
yes, and that was our in vitro setup, so the small cylinder essentially. So we matched, we were able with our model to match lesions there with experimental setup, so we were confident. And then whenever we try to add things in the model, of course, we go back and we test whether we can match, we can still match.
And then my second question, since you study this, if I had to do an ablation of my heart, what do you recommend?
It's a tough question. It really depends on the type of arrhythmia. So I would trust the pulse field ablation because they just throw millions, not to say billions, and the market is exponentially increasing for this right now, but only when it comes to atrial arrhythmias. So if there is atrial fibrillation or something like that, atrial fibrillation, essentially the muscle twitches the atrial wall. So then I would definitely go for this one. But even like with this energy, depending on the catheter, they observe different things. So it's very company driven. They don't give any data available. The waveforms are not available. So we don't know.
3% risk of stroke then.
For the Johnson & Johnson, for example. But there is Medtronic. I agree. I completely agree. With Medtronic or Boston Scientific, which were the first two that they got an FDA approval, they seem to have better results, but still the 1 year outcome is comparable to radiofrequency. So it depends on the center. If you want to go to the one that has been the most researched, let's say, then for this one, radiofrequency. If you would like to go for something that you know that the fatal complications are not as dramatic as here, then I would go for the pulse field. I really hope you don't. Nobody else pass it. It's part of life, but yes.
No more questions, just a very short one, but it's right at the beginning you say that RFA is minimally invasive. Why would you say that a procedure where you have to burn the heart tissue is minimally invasive? What's an invasive procedure?
Open heart.
Exactly. Open heart.
So maybe this was kind
So
Leaving the tissue scarred forever is not sufficiently invasive.
Okay, they have to cut.
They don't have to cut.
They just a small cut.
in the past they were cutting, in fact, and they were sewing together. So it's definitely less invasive than that.
Okay. Fair enough. Okay. If nothing else, thank you very much again.
Thank you.